My name is Professor Ofer Nativ, and I am the chairman of the Department of Urology at the Bnei Zion Medical Center in Haifa, Israel. In the last years, my colleagues and I are trying to find ways to improve the management of non-muscle invasive bladder cancer. In this short video, we'll talk about a new article recently published in the Journal of Urology, written by urologists from experienced centers in Europe and Israel, including myself. This article focused on a special and rather difficult group of bladder cancer patients, those whose tumor has recurred after treatment with BCG, which is currently the gold standard of non-muscle invasive bladder cancer treatment. Treatment failure after BCG indicate a more aggressive disease and put the patient at an increased risk for tumor progression and the development of distant metastasis. Because of this increased risk, and according to the commonly accepted guideline of both the European and American Urological Association, most of these patients are offered radical cystectomy. This operation involved mortality, a high morbidity rate, including the need for reintervention, and a significant decrease in the quality of life of the patient. For this reason, many of the patients who failed BCG treatment seek other, more conservative treatment options. Furthermore, some of these patients cannot undergo radical cystectomy because of other concurrent comorbidities. We studied a group of 111 Ta/T1 patients who failed previous BCG. Rather than having their bladder removed, all patients were treated with a novel technology combining radiofrequency-induced bladder wall hyperthermia and concomitant instillation with a chilled mitomycin C solution. This technology is called Synergo. The direct heating of the bladder wall is achieved by the specific capability of radiofrequency energy to penetrate deeply into the layers of the wall. The effect of hyperthermia has a few mechanisms. One, heat may directly and selectively kill the tumor cells. 2. Heat dilate the tumor's brittle blood vessels, causing the rupture. 3. Heat significantly increases diffusion, thereby improving drug penetration into the tumor cells. 4. Heat increases the rate of chemical bonding of MMC to the DNA, thus enabling more DNA destruction. Finally, it reduces the activity of DNA-repairing enzymes, and in so doing, it prevents the saving of damaged cancer cells. In our 111 studied patients, the Kaplan-Meier estimated recurrence rate at 2 years was 44%. Only 3% of the patients had progression of their tumors and lost their bladder despite the Synergo system. It is important to remember that patients who failed BCG treatment are not the only ones in the group of non-muscle invasive bladder cancer patients difficult to treat. Other groups include the T1, G3, and CIS patients. I would like to focus on two recently published other articles, one by Professor Fred Witches from Radboud Hospital in Nijmegen in the Netherlands, who studied 49 patients treated with Synergo for carcinoma in situ. 92% of the patients had a complete response, and about half of the complete responders maintained their tumor-free status after a mean follow-up time of 27 months. Even in this most difficult group of patients, bladder preservation rate was 86%. Another study by Dr. Sarel Halachmi from our department, who evaluated 51 eligible T1 G3 patients treated with adjuvant Synergo. Also here, the estimated recurrence rate was only 43% at 2 years and 51% at 4 years. Progression rate was 7.9%, a fairly low rate for such a high-risk group. Other treatment options for patients who failed BCG treatment were also studied. When looking at the percentage of patients remaining tumor-free 2 years after completion of therapy, one can see that valrubicin, another cause of BCG, mitomycin cis treatment, and a combination of BCG and interferon alpha all gave less favorable results when compared to the Synergo system. When treating patients early enough, before they became highly recurrent, results with the Synergo system are even better when as many as 72% of the patients remain tumor-free at 2 years. It is important to know that this treatment takes about an hour and is associated with pain and bladder spasm in some of the patients. But this can be easily managed, and the withdrawal rate in this study was only 5.4%. In conclusion, we present a safe and effective technology for the treatment of non-muscle invasive bladder cancer patients who failed on BCG without exposing them to an increased risk for tumor progression. This treatment may even have the potential to prevent or at least to delay the radical treatment of cystectomy. Thank you.